So with that little bit of background, I'm going to introduce our first speaker, Dr. Paul Palevsky. He's the chief of the renal section at the VA Pittsburgh Healthcare Center. He's a professor of medicine at the University of Pittsburgh School of Medicine. And he's going to be talking to us on hyperkalemia, who, why, and where.
Thank you for that kind introduction. So I'm charged with talking about the regulation of potassium and why patients develop hyperkalemia. My disclosures, none of which are relevant to this topic. So let's go back to the basics. Potassium is the most abundant cation in the body, a monovalent cation in the body. Most of it is in the intracellular compartment, 98 to 99% of the total body potassium, where it's at a concentration of between 120 and 150 millimoles per liter. In the plasma, there's much less potassium at a concentration, as we all know, between normally 3.5 to 5 millimoles per liter. And that this concentration gradient between the intracellular and extracellular compartments, combined with the differential conductance for potassium relative to sodium across the cell membrane, is the major determinant of the electrical gradient across the cell membrane, which is so important for driving so many physiologic processes. Now, if the potassium level in the blood rises, we see many different manifestations. Cardiac manifestations, as you well know, the EKG changes, and this just shows the characteristic changes that would be seen as the serum potassium increases, conduction abnormalities, and arrhythmias, ultimately ventricular fibrillation. Hyperkalemia is also associated with muscle weakness or paralysis, and on a chronic level, hyperkalemia results in reduced renal acid excretion as a result of decreased ammoniogenesis and excretion. When we talk about potassium homeostasis, we need to consider two different processes. We have intake and excretion, which is the external balance, and we have the regulation of potassium distribution between the intracellular and extracellular compartments that we refer to as internal balance. Now, our external balance is determined by our dietary intake, which is, as Dr. Palmer pointed out, much lower today than believed to be the case historically. Dietary potassium tends to be on the order of 50 to 150 millimoles per day. Patients also have potassium intake as a result of salt substitutes at times, so it's an important thing to think about when a patient is hyperkalemic. If they're on a low-sodium diet, are they using a salt substitute that uses potassium chloride rather than sodium chloride? Prescribed oral supplements that we give our patients, or iatrogenic administration. Excretion is predominantly via the kidney. There's a small amount of extrarenal excretion in the stool and cutaneously. Now, the renal potassium handling, potassium is freely filtered at the glomerulus. 65% of the filtered potassium is usually reabsorbed in the proximal tubule, and 25% in the thick ascending limb of the loop of Henle and the distal convoluted tubule. This results in less potassium in the tubular fluid reaching the cortical collecting duct than often needs to be excreted. And in the latter portions of the distal convoluted tubule and into the collecting duct, we have potassium secretory mechanisms, which are the major determinants of potassium excretion. So this is from the physiology series in C. Jason from Dr. Palmer's contribution on potassium, illustrating the potassium handling in the distal convoluted tubule. And if we focus on the latter half of the lower cell here, in the latter portion of the distal convoluted tubule, this is an aldosterone responsive cell that has an epithelial sodium channel and a potassium channel, and there is electrogenic sodium reabsorption, creating an electronegative gradient that drives potassium secretion. In the collecting duct, the principal cell, again, aldosterone-sensitive cell with the electrogenic sodium channel and with potassium channels, and again, potassium being driven by the generation of electronegative gradient. Now, how do we regulate renal potassium secretion? There are a number of factors. Dietary potassium directly may have a control over potassium secretion, as does the serum potassium concentration. As the potassium concentration increases in the extracellular fluid, it increases the gradient for potassium secretion. Aldosterone is the major hormonal regulator of potassium secretion. Increasing aldosterone levels increases the activity of the sodium, the epithelial sodium channel, increasing sodium reabsorption, increasing the electronegativity in the lumen and stimulating potassium secretion. Distal tubular flow rate is also an important regulator. The cells within the collecting duct and the distal convoluted tubule actually are able to detect flow rate, and the potassium conductance will increase as distal tubular flow increases. Distal tubular sodium delivery is also important. As you increase distal delivery, there is more sodium reabsorption, and that stimulates potassium secretion. And the distal tubular anion concentration is also important. Anions other than chloride are less well reabsorbed in the distal tubule, increasing the electronegativity within the lumen and stimulating potassium secretion. So this is illustrated here in the low flow, the effect of flow on potassium secretion. So on this side you have the low flow state, and on this side the high flow state, and as flow increases there's a stimulation of the sodium conductance, and as well increased potassium conductance in the, this shows it in the distal convoluted tubule, and it's also in the collecting duct. So what is the relationship between between volume status and potassium secretion? So in extracellular volume contraction, there is activation of the renin angiotensin system, stimulation of aldosterone, stimulating potassium secretion. At the same time, there is increased proximal tubular sodium reabsorption, decreasing distal sodium delivery, which will inhibit potassium secretion. Thus, we are able to maintain sodium balance independent of potassium balance. So in this case, as you become volume contracted, you increase your sodium reabsorption while maintaining a constant level of potassium secretion. These effects are also affected by differential effects of aldosterone and angiotensin on tubular handling. So in the setting of volume depletion, you have aldosterone stimulated in the setting of elevated angiotensin levels, The elevated angiotensin downregulates potassium conductance in the aldosterone-sensitive sections of the nephron. On the other hand, hyperkalemia is a direct stimulus of aldosterone, and in the setting of hyperkalemia without volume depletion, you'll have lower angiotensin levels but stimulated aldosterone, so that you get greater stimulation of potassium secretion, again allowing differential regulation of sodium and potassium excretion. Now, what are the regulators of internal balance? These include insulin, catecholamines as physiologic regulators, and pathophysiologic influences include acid-base disturbances, hypertonicity, cell proliferation and cell lysis, cell membrane disorders such as seen in hyperkalemic periodic paralysis. So what is the relationship between potassium and insulin? Potassium is a direct insulin secretagogue. So hyperkalemia stimulates the pancreas to release insulin, and that insulin stimulates potassium uptake both in the liver and in muscle. So we have food in front of us on the tables, including some high potassium foods. That's going to stimulate insulin release and potassium uptake into the liver, so that the potassium load from our diet doesn't result in acute hyperkalemia. That potassium will then be slowly released from the liver and taken up into peripheral tissues. The regulation of potassium uptake by muscle, by insulin, and by beta-adrenergic stimuli actually occur via separate pathways. So insulin stimulates the phosphatoinositol 3 kinase system, whereas beta agonists work through cyclic AMP, but both ultimately stimulate the activity of the sodium-potassium ATPase, stimulating potassium uptake into the cells. And you'll note that the control of potassium uptake by insulin is actually independent of the regulation of glucose. The effects of insulin and beta stimulation on potassium intake are the fact that they're independent is illustrated here, and the fact that they're additive. So this is from data looking at treatment of hyperkalemia, and you can see the effects of insulin in purple, albuterol in green, and the combination of albuterol and insulin in orange, showing the additive effects. Acid-base disturbances have an influence on potassium homeostasis, and there's an important difference between the hyperchloremic metabolic acidoses, which will result in hyperkalemia, and the organic metabolic acidoses, which generally do not directly cause potassium efflux from cells. And it's thought that this is related to differences in how the acid load is buffered by the cells. In hyperchloremic metabolic acidosis, you have hydrogen sodium exchange. In the setting of acidosis, you downregulate the sodium-hydrogen exchanger. That results in a reduction in the sodium concentration within the cell that downregulates the activity of the sodium-potassium ATPase. In organic acidoses, the entry into the cell is by non-ionic diffusion, not resulting in a change in the intracellular sodium, and not resulting in a change in the activity of the sodium-potassium ATPase, and resulting in no or minimal change in the serum potassium concentration. Bicarbonate has an independent effect on potassium distribution, stimulating potassium uptake into cells, but this is a slow process, which is why bicarbonate is not effective for the acute management of hyperkalemia, as illustrated in this study by Blumberg et al. From several decades ago. The effect of hypertonicity on potassium distribution: as the cells become hypertonic, they shrink, the intracellular potassium concentration increases. There is efflux of potassium as a result of the bulk flow of water out of the cells, and at the same time, to the extent that the potassium remains within the intracellular compartment, the increase in potassium concentration moves it away from its equilibrium so that you get a downward shift of potassium into the extracellular fluid. We can see pseudohyperkalemia in patients, and this is very important to recognize clinically. I think we all recognize the effects of severe thrombocytosis with platelet counts greater than 500,000 to 1 million, leukocytosis with white cell counts in excess of 50 to 100,000, particularly in patients with myeloid leukemia. Less well recognized are that there are patients who have a variety of erythrocyte membrane defects that result in a tendency towards potassium exit from cells. Some of these, important to recognize, are only seen ex vivo as a result of having the blood at cold temperature, so that there is an efflux of potassium from the red blood cell when it is refrigerated, which may happen in transport from when you draw the blood to when it gets to the lab. So it is important in patients who have these membrane disorders to make sure that the blood is separated before it is cold. It is cooled. Plus, we can get improper phlebotomy technique, prolonged tourniquet times, fist clenching, as phlebotomists frequently ask our patients to do, that cause potassium release, or blood draw through catheters with excessively rapid drawing of the blood, causing a degree of hemolysis and artifactual hyperkalemia. So what are the etiologies of hyperkalemia? We can have disturbances of external balance. Given the tremendous ability of the kidney to excrete potassium loads, it is rare that dietary intake results in hyperkalemia in the absence of some impairment of renal potassium excretion. Reduced excretion may be due to reduced GFR, such as in acute kidney injury or patients with advanced chronic kidney disease. More commonly, we see issues related to impaired distal tubular potassium secretion, such as patients who have aldosterone deficiency or tubular resistance, and in patients who have hyperkalemic distal tubular acidoses. There are a variety of medications that we give our patients that may inhibit the potassium excretion, blockers of the renin-angiotensin system, mineralocorticoid antagonists, potassium-sparing diuretics, trimethoprim, which inhibits the ENaC directly as if it were a potassium-sparing diuretic, nonsteroidal anti-inflammatory drugs, and the calcineurin inhibitors. When we have, going back to this schema that I showed before, if we give nonsteroidals or RAS blockade, we inhibit the renin-angiotensin system, mineralocorticoid antagonists, or hypoaldosteronism, decreasing the aldosterone secretion, so that in the setting of volume contraction, we're no longer able to maintain normal potassium secretion. So patients who are on an adequate salt, who have a high sodium intake may not develop hyperkalemia, but patients, as they're put on sodium restriction, may develop hyperkalemia. And this sometimes occurs as we admit the patient to the hospital. They may be normal kalemic on admission, but as they have their enforced low sodium diet, they become hyperkalemic during hospitalization. Internal balance, metabolic acidosis of the hyperchloremic form, hypertonicity, insulin deficiency, cell lysis is seen with hemolysis or rhabdomyolysis, and a variety of pharmacologic agents that alter the balance between the intracellular and extracellular compartments may contribute to the development of hyperkalemia. And finally, patients with hyperkalemic periodic paralysis. So let me conclude then with the who, why, and where. In the outpatient setting, we generally see hyperkalemia in patients with mild to severe CKD, particularly with concomitant diabetes, heart failure, obstructive disease, or post-transplant, often exacerbated by medications that we give our patients, such as RAS blockers, mineralocorticoid antagonists, and nonsteroidals, or in the setting of volume depletion, such as diuretic use or GI losses. In the hospitalized patients, we're dealing with patients with acute illness, frequently with AKI, and frequently internal shifts in potassium. So with that, I thank you for your attention. I think questions will be at the end, and